after us understanding how anemia can be classified or can be graded, now let us look at the diagnostic evaluation. What may be the steps we may need to diagnose anemia, especially in pregnancy? One, we need both the subjective data and then the objective data. And for the subjective data, we take history. So here, a mother may report history of chronic illnesses, behaviors like easy fatigability, etc. So during history taking, if the mother tells you, I'm chronically having malaria, I'm chronically vomiting, I'm having hyperemesis gravidarum, I'm weak, I cannot do every work. Therefore, in your mind, you think about this mother being anemic. And also, sometimes these mothers report about pica. Pica is excessive craving of non-food particles. These mothers may be, some pregnant mothers eat soil, eat clay, etc. And here, most of them, they are having a deficiency of iron, and they feel like it is present in what they eat. So this is one of the diagnostic evaluation when you start to think about whether this mother may be having anemia. Then from that, we go to our objective data, that is physical examination. So here we examine for anemia by checking for the pallor, one of the conjunctiva, of the tongue, of the gum, of the palms, of the vagina, and of the feet. We think of the pallor. We also check out for capillary refills. So all these are tests or examinations in assessment of pallor. Then lethargy, the mother might be weak, biffid tongue. Then we have cholinecia. Cholinecia, how can I explain? They are grooved nails. These are key in sickle cell patients. Then palpitations, tachycardia, and tachypnea. These may be key signs and symptoms during physical examination of a mother with anemia. Then after that, we shall go ahead to do laboratory investigations, and here we shall do a full blood count, which will show us the three classifications. Basically, the morphological classification. How does our cells look like? How do the cells look like? Are they normocytic, normochromic? Are they microcytic, hypochromic? Are they macrocytic? So the CBC will show all that. Then we can go ahead to do a bone marrow assay to look at how the bone marrow functions, to rule out anemias or like B12. Then stool analysis. Here we are going to check out like things like hookworm infestations or blood in stool, which may lead us to diagnose chronic hemorrhage. And we do other tests like malaria tests, sickle cell tests to rule out other possible causes. So we may have a differential diagnosis. Differential diagnosis, we may think that this mother is anemic, yet this mother is having a nephrotic syndrome, is having a cardiac disease, is hypertensive, or even having a leaking ectopic or molar pregnancy. So if the mother is anemic, we wouldn't completely rule out these conditions. We should be able to go ahead and assess whether these conditions are also prevailing, which will help us have a better management. Now, after assessment, classification, let us look at the management. And here management will depend on the severity of the anemia and also the gestation age of the mother. We have talked of investigations, and our first point in management will be history taking. Second is examination, and then investigations. And here under investigations, there is a lot of investigations we can do to rule out the kind of anemia this mother is having. Then we are saying, in case of mild to moderate anemia, investigate and treat the cause using the guidelines. Here we are using the essential maternal and child care guidelines 2022. So they are the ones we are going to use in the management of this mother if this mother is found to be anemic. And in case of severe anemia or in cardiac failure due to anemia, this mother should be referred to hospital for admission. So what does it mean? Mild to moderate anemia can be managed at home. This mother can be managed and then sent back home and then followed up specifically in few weeks. But when you have a mother with severe anemia in cardiac failure, this mother should be referred to hospital for admission. And for this mother who is being referred to hospital, as you transfer this mother, rest the mother in a propped up position. If possible, give oxygen by face mask, accompany the patient and reassure, because this mother is severely anemic. And when you reach hospital, prepare the resuscitation tray, transfuse. Preferably, if this mother is having hemolysis, may need packed cells, but if this mother is having hemorrhagic, may need full blood, and they should be covered with a cover of furosemide. Furosemide is going to help us avoid excessive fluid, to avoid fluid overload. So now let us look at the specific interventions for all grades of anemia which require treatment modalities. If this patient is not in severe anemia, she's having mild to moderate. This is the key things we must do. Administer iron and folate supplements as prescribed. I think this is always done on antenatal. Encourage a nutrient-rich diet. I think all the midwives do this under health education talks. Monitor hemoglobin and hematocrit levels. I believe this is always done at the first antenatal visit and periodically. Assess for signs and symptoms through general examination. Encourage rest and energy consumption. So if the mother feels like weak, let her rest. And monitor fetal well-being. That is very key, because if the mother is affected, it means even the baby will be affected. Teach proper supplement intake. Manage gastrointestinal side effects of iron supplements. Other mothers may be vomiting whenever they take ferrous or folic, so we should be in position to manage the side effects of the drug we give. Promote infection prevention measures. This is done preferably by government, by issuing the insecticide-treated nets, basically to prevent malaria in pregnant mothers, and other infections that may lead to blood loss. Provide emotional support and counseling, and transfuse if there is severe anemia. We have said if this mother is transferred to hospital, this mother is going to be transfused. And here there is a note that each unit of blood raises the hemoglobin by 0.7 per deciliter. So aim to bring the hemoglobin level up to 10 grams per deciliter and limit transfusion to only 3 units per day. So this is a very big caution during management or during blood transfusion. So add vitamin C to improve absorption, deworm the mother with mabendazole 500 milligrams start or albendazole 400 milligrams start, but remember, not in the first trimester. We shall start in the second trimester. Counsel on prevention of hookworm infestations. Let this mother learn to wash the mangoes. You know, as they are walking around, they pick the younger mangoes and eat spontaneously. They eat the soil. So these are all sources of hookworm infestations. So as we talk to them during antenatal, they should be in position to prevent hookworm infestation. Counsel on compliance of treatment, that is taking their ferrous and folic. Most of them, they are vomiting, they don't want to take the drugs, but let us counsel them on compliance with the treatment, and then always review after 2 to 4 weeks. So this is the general management of the mother, irrespective of the gestation age. All these things should be done to a pregnant mother.